Well, I think this discussion of Gambrill's Chapter 12 is going to be a bit shorter than the last two. You might like that, maybe not, I don't know. But I wanted to do this presentation, this chapter, separately from the other chapters because I think it's interesting to compare Gambrill's take on the assessment process with the Hepworth group and Cournoyer's look, which I think, although they talk about environmental issues, the person and environment, and bringing all that into the picture, really still focuses a lot upon the individual. I think maybe primarily upon the individual and identifying the kinds of things that need to change with that individual. Now that is a legitimate approach, and it is the one you're going to find used by most people in treatment field. But Gambrill cautions us to remember that there's a much bigger picture involved, and if we're only looking at what's going on with the individual or his or her immediate world, we're missing a lot of what needs to be dealt with in order to change the behavior. So, or to improve the client's situation. Also, we talked about critical thinking and the whole pursuit of knowledge and what knowledge is, and which is also going to tie very much into this contextual assessment framework. So if you see things that appear to be repetitive, kind of take that to be those points where other other chapters and other approaches that we've talked about tie into her idea about a contextual assessment. So in going through the Cournoyer and Hepworth groups ideas about assessments, really, I think, although they did mention that assessment occurs at different phases of the our work with our clients, nonetheless, I think a lot of their assessment focus, their information about assessments focuses upon the early stages of our work. And Gambrill points out that this assessment is something that we really need to be doing throughout our work. Is progress being made or not? And if it's not, we need to go back and look at our assumptions in the assessment and look at our assessment and our conclusions and consider revising those things, altered as needed in response to any new information that we get. Assessment frameworks that focus upon pathologies of clients result in overlooking the resources and the strengths that the client has, and approaches that focus upon deficiencies prevent us from focusing upon those strengths with the clients, that the things that they can use to really attain their what they want to attain. And so she proposes, as in opposition to the pathological dash deficiency based approach, to take a contextual dash constructional approach. You can kind of compare the two terms before and after the dash there to get the comparison. That this contextual constructional approach allows for us to consider client characteristics and circumstances that include such things as alternate behaviors that might compete with undesired behaviors successfully. An example, when I was in grad school, I had a behavioral methods course, and one of the things that we were tasked to do, was our term project really was to develop, design and implement a self-modification program. And I was smoking at the time, and smoking a pipe, and targeted that as the behavior I wanted to change, to quit smoking. And actually, I'll just tell you, the program that I set up was successful and achieved the goal. Although I failed to put in that maintenance thing at the end. I think I had something set up for maintenance, but it wasn't a strong enough program, and I started smoking not long after the semester ended, after I got my A. But that wasn't why I quit, of course. But anyway, I digress. The point is, one of one of the things that I built into my self-modification program was the notion of an alternate behavior, an incompatible behavior. So that rather than focusing upon reducing the amount of time I smoked my pipe, or the amount of tobacco I used, or whatever that may be, instead of focusing upon that deficient behavior, instead the focus was placed upon increasing the length of time where I wasn't smoking, increasing the length of time between times that I lit my pipe. And so my program was to gradually increase that time. That was incompatible to smoking, as you can imagine, so that eventually smoking was off the schedule altogether, pretty much. And so that's an example of where we can look at the things the client can do instead of looking at stopping, changing the things they are already doing, and that's the notion of alternate behaviors that compete successfully with undesired behaviors. And of course, contextual assessments also give us an opportunity to look at environmental resources like social support and to make use of them, and to also look at the policies and legislation and practices in the agency and in the government and in society that restrict or provide resources to our clients as well. Evidence-informed assessment is a part of evidence-based practice, and so we have to ask such questions as, what are the assumptions we're making? Are there well-argued alternative views, and if so, what are they? Is the information the sources of information that we're relying upon accurate? Are the measures that were used in whatever study that was done, whatever approach we're looking at, are they reliable and consistent measures? Have we avoided those common kind of errors, like only looking for the things that really support what we already believe, or did we jump to conclusions too quickly, like only just accepting one study because it sounded good? Those kinds of things. Of course, have we considered the client's views and preferences? That's a a critical part of the whole evidence-based practice approach. And this says, is there evidence that assessment methods do more harm than good? And that reads okay. I would prefer to say it the other way, which is, do our methods do more good than harm? But either way, it means the same thing. These are things that we need to ask ourselves in that assessment process. Now, there are some assessment frameworks that are used that are really used sometimes with very little evidence of their effectiveness. And a genogram is one of them. Now the genogram used in an assessment, there are claims that genograms are a good way of assessing an individual's and life circumstances, and there really is very little support for that as far as any kind of rigorous testing is concerned, as Gambrill points out. Now, genograms in general, I think, have a utility in treatment and helping people understand things in their family system, perhaps. And actually, we used genograms in a sociology course on the sociology of families that I taught many years ago, and several of the students actually made connections with people in their family they hadn't connected with in years, and in and of itself seemed to be a worthwhile effort. But again, my own evaluation, anecdotal evidence, take that for what it's worth, but I'm not talking about using it there as an assessment tool. Genograms have their place, I guess is what I'm saying, but probably not as an assessment tool. The infamous Rorschach ink blood test, of course, we know that there's a lot of issues with validity with the results of that, and when you still psychologists persist in using this test and relying upon it heavily, in fact, in many psychological evaluations as a good projective test. So, when you read those things, I'd say, take the results of that for what they're worth. And hopefully there's some more valid and reliable testing in the psychological assessment that you're looking at for your client. And if not, you might want to go ahead and do another assessment. Of course, as we've been talking about, DSM labels, diagnoses are given to clients, even though there's a lot of issues with the reliability and validity of those systems, because it is, we'll be touching on that in a few moments. Counselors have been known to create false memories in clients just by suggesting and encouraging clients to dig further back. And in fact, I don't anymore, but I knew one therapist who, well, I without attributing motivations to the work that this person was doing, spent quite a bit of time with female clients looking for perpetrators whenever that therapist thought that the client's behavior suggested there had been sexual abuse in the client's past, and I think a lot of times, I think some false memories were created in that. And what that kind of approach does, of course, is undermine the whole notion of recovered memories and those kinds of things, which can be very valid and very important in treatment and sometimes even in prosecution of sexual abuse cases. But anyway, that's another thing that you know, in an assessment process we should be cautious of. And self-reported clients really needs to be checked against, do observations or at least hear what other people around that client says, because self-reports alone are probably not a reliable source for an assessment. And Gambrill points out that social workers really don't know how to do a good behavioral analysis, and I think that's probably true. And one of the reasons why I avoid spending too much time on the behavioral issues that she writes about in the chapter Behavior Treatment. There's a lot of behaviorism stuff in later in the chapter. And we're going to touch on some of it, but we're going to miss some. We're going to skip over a lot of that stuff as well, because I think you really need a course or two or three or four in order to become a good behavioral specialist. You're not going to get it in the context of this class. It's really outside the capacity of things we can do. So watch out for pseudoscience, because a lot of us rely upon pseudoscientific studies, and sometimes the pseudoscientific studies do more harm than good, and so it's very, very important to to avoid that in the assessment process or in reviewing assessments, to be aware of that. How we frame client concerns has a lot to do with whether we help or hurt. The process of discovering the options available to clients. And again, Gambrill doesn't like that biopsychosocial, or she calls it biopsychiatric approaches, because it focuses upon what's wrong with the client and really doesn't take that constructional approach that she prefers, that identifies strengths and resources. And you can see, depending upon which approach you take to assessment, what the results are going to be, probably just from looking at the comparison of those two. Now, I will also point out that a lot of the times the approach that we take has to do with who employs us and what we're told to do, what kind of assessments we do. And if we're not doing the kind of assessments we think we should, it's okay for us to advocate with our employer, but sometimes you don't have the freedom to choose here, other times you do. Now, about framing of problems and everything, the notion of blaming, looking for the what's wrong with the client and that kind of thing. She refers to the war on drugs in this, and really, in a sense, this is really even looking at contextual assessment of society, not just of the individual problem of drug abuse. But this points to the fact that when we look at the problem being the substance abusing person, and the sale of those drugs by individuals, that is the problem when it comes to substances, then what that does is, what we have done, that's what the war on drugs is all about, is focusing on individuals and stopping people from selling drugs and getting people off of drugs. And in the process of doing that, what we've done in our society is to criminalize the sale and use of non-prescribed drugs. Skipping down to the end here, Portugal in 2001 decriminalized the use of all drugs and has seen a decrease in the use of drugs since that time, which is an interesting thing that may explain a little bit about why there's our war on drugs not being successful. We may be going about this the wrong way, but look at what happens when we criminalize the sale and use of non-prescribed drugs. A whole industry pops up around the treatment of drugs and drug abuse, and a whole industry pops up around probation and parole and prison system, to house these offenders. And I will add, the social work industry also, is developed because we work in all of those settings, as well as like in child protection, for instance, where some children are removed from severely substance abusing parents, and sometimes not even severely substance abusing parents. And so in a large respect, the helping industry, the social work profession, in a sense, benefits from this war on drugs. We benefit from the individual focus on our clients. not to mention the pharmaceutical industry, which it creates these opioids, for instance. I, 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 um, I don't remember the name of the what company it was that developed the oxycontins. It's just slipping my mind at the moment. But lately, they have been in the news because they have developed a treatment now, a drug that can be treated to be used to treat opioid addiction and to get people off of their addiction. So isn't that interesting that the problem is created in their factories, so to speak, and lo and behold, now they're making money treating that problem that they created. So that's again another outgrowth of this war on drugs. So more misuse of prescribed medications and more jails being filled in. And this is the another issue, and perhaps the big issue here, which is that the jails are filled with minority youth. I think we've touched on already the fact that the poor African American users of drugs are jailed for the use of drugs that middle class whites are sent off to treatment programs to deal with. Sometimes very cushy treatment programs, in fact. So the jails are filled with not just youth, but minority individuals who have grown up in neighborhoods where there are few mainstream opportunities for employment and education and recreation and those kinds of things, which really has a lot to do with the fact that they're using and selling and distributing to begin with. And so more arrests, more sales, more use, and all of this, well, I mean, is focusing upon the individual and curing that addiction may be necessary, but is that the answer to resolving the issue of drug abuse in our society? And certainly the opioid addiction has become a crisis in our society, and I think the evidence is pointing in the other direction. So this is one example of why we want to look at the context of these problems and not just kind of focus on the individual we're seeing. Now, resolving these issues probably is going to be bigger if you're hired as a substance abuse treatment professional or you're a social worker working a child protection caseload. It's a bigger issue that you're not going to be able to resolve from your desk. But A, having the knowledge of it tells you a little bit about how to approach things differently, I think, and B, may give you some basis for some social advocacy. So we can't just look at the characteristics of the client, but we also have to look at the characteristics of the environment in which the client resides in order to figure out the proper outcome, how we go about achieving the outcome. If we focus too narrowly on one source, then those environmental contingencies are going to be overlooked. And that is what is referred to here and elsewhere in this text as the fundamental attribution error. That we make that error when we attribute behavior to the characteristics of the individual, overlooking the environmental causes and cues to that problem. We have to consider the entire context in order to understand the behavior. Again, the issue with poverty is a great example of that, blaming the welfare recipient for being poor. And that's a wonderful example of the fundamental attribution error, blaming the substance abusing clients for their abuse of drugs and alcohol. Again, a fundamental attribution error when you look at it in the context of the war on drugs. Now, I was talking in an earlier lecture, the diagnosis was referred to as a snapshot, and I told you we'd connect with that, and here we are. The diagnosis identifies a condition that a client is believed to have, whereas an assessment encourages a description of processes impacting the client. So the diagnosis is like a still photograph, that snapshot, in comparison to the assessment, which is much more like a motion picture. And I like the comparison that those two phrases, to look at, because it really illustrates the difference, what we're looking at here. So that our assessment should include a clear description of the behaviors of concerns, and all those factors that are related to that behavior, all those things from the environment and the context, description of what the person is capable of, what can be learned, what can be expected, and what those environmental factors are that influence the behaviors and how they impinge upon what they're capable of and what can be expected. Now, as we mentioned earlier, you a lot of times you're going to be diagnosing clients strictly for the purposes of third-party reimbursement, but that doesn't have to stop you from continuing on and doing a good contextual assessment. The Gambrill writes that one danger is believing there is no need for an assessment because a label has been given. We may think our work is over when we give a person a diagnostic label rather than realize it is just beginning in relation to the need for a contextual, evidence-informed assessment. Again, we don't want to stop with that still photograph. That's the diagnosis. That's not the end. The end is a motion picture, putting together that motion picture, which will continue to change as time goes on. So when we do provide diagnoses, we want to make sure, we'll ask, are they helpful? When are they helpful? Sometimes they are helpful. When are they irrelevant? When do they mislead or hurt our client? Do they offer any help at all and offer any guidelines in providing help for our clients? And what are the assumptions that underlie those labels? So the problem with the validity of the DSM has to do with how it's formed, and you're probably aware of this, but there's experts from around the world, psychiatric and psychological experts. They're all involved in reviewing these diagnoses and talking about, it's a consensus kind of conclusion in the end. That it isn't unanimous by any stretch of the imagination, and there's not necessarily testing that's being used, but it's a consensus and agreement among these supposed experts around the world about what constitutes which disorder, what behaviors are seen. And so certainly there's a lot of cultural implications with that as well. But part of the other issue is that there's a lot of conflicts of interest in this. And Gambrill points out that many of the people that are on the boards or the committees or whatever that develop all these disorders have close ties to the pharmaceutical industry, for instance. And again, big pharma benefits here because the more psychiatric diagnoses are out there, the more drugs are needed, and so there's good reason to question I, I don't believe that I'm not suggesting at least that the individuals involved in DSM are intentionally hoodwinking those of us in the helping professions and clients around the world, but it may be happening in spite of themselves. These labels, she says, the labels are supposed to be, as we talked about earlier, useful in communicating among many different professionals from different disciplines. What is the complex of behaviors that the client presents, and what does that mean? So these labels are supposed to tell us these things. But she says this would only be true if the labels were valuable in helping clients. Now, they're recognizing the signs of pathology can be important if it increases our understanding of what can be accomplished and how we go about that. So it isn't that diagnostic labels are totally useless, but we have to understand them for what they're worth, and don't let those labels describe our clients for us, but perhaps describe some of the behaviors that are being seen, at least observed by some people. Of course, Thomas Daz, again, that was the Myth of Mental Illness was the name of his seminal work, I think back in the late 60s, early 70s. And he said mental illness was neither mental nor was it an illness, that what it does is it takes problem behaviors and turns it into a health issue, a medical issue, and that gives the medical industry and the psychiatric industry, it extends their domain of control much more widely than than it would otherwise be. And so he says we should see mental illness as a metaphor, really, that what it all comes down to is problem behaviors. One thing to support that is, and I'm not sure where this little tidbit of information comes from, but I remember reading one time that the decisions made by psychiatrists as far as release, or rather admissions to psychiatric hospitals, those decisions usually are not so much, are not made by the psychiatrists, are made by family members. That family members, professionals will time and time again ask family members what's going on with the person. And as long as the family member gives indications that they can deal with the behaviors, then the person continues in the community. But one thing happens that kind of, the straw that breaks the camel's back, and the family's had it. And then suddenly there's justification for admission to a hospital when it really isn't any different than what's been going on all along. And likewise, they say that the release from hospitals oftentimes are made in the same in the same way, that it's less the decision of the psychiatrist and more the decision of the people who are going to be receiving that person. So again, it just, and you're familiar probably. Maybe I even posted in assignments again, but it's one of my favorite old readings that I like my students to read. The on being sane in insane places, about the whole notion of psychiatric diagnoses, and how it's the professionals can't tell the difference between an individual who may be legitimately mentally ill and one who is faking mental illness. And Gambrill points out, by the way, that our vaunted PIE system has the same validity problems that the DSM has. So there you go. So make your assessment strength-based. Look at the client's assets, and we want to help them identify their strengths and identify their support systems. What's going well in their lives? What can they contribute? Look at the positives that can be used to construct behaviors to reach that desired outcome. Now, a few distinctions here that I like these little sections. For one thing, the form of a behavior does not indicate its function. So identical behaviors can be maintained by different contingencies. Now, contingencies, remember, or maybe we haven't read this yet, but we're talking about the antecedents, what happens before the behavior, what happens because of the behavior, and the things that cause behaviors, such as acting out in the classroom or whatever, oftentimes have to do with what's going on in the environment. It isn't about what's going on inside the child. So we may treat the child with medication to have them calm down in the classroom, when really it has to do with cues in the classroom that stage the behaviors, and consequences, how the teacher, let's say, responds to that. That's where observations come in. But in any event. Well, that's what behavior analysis requires, both a functional and a descriptive analysis. Not only what is the behavior, but how does it what sets it off, basically. What is the antecedent? What is the consequence? So form and function are different. If a desired behavior doesn't occur, its absence from repertoire may be a behavioral issue, or it might be a motivational problem. If there's a lack of skills, then the intervention is teaching the person how to engage in the desired behaviors. But if the behavior is not reinforced on a schedule that's effective, then it could be a motivational issue, and your approach then is an entirely different approach to treating it. So again, this is a part of that. You have to look at the environment. You have to look at the context of the issue to understand how to approach it. And as pointed out here, of course, emotional reactions often interfere with desired behaviors as well. So our contextual assessment framework is tailored to the individual, isn't vague. It really avoids stereotypes, and it avoids the use of untested beliefs as much as possible. It has a clear description, a concrete description of client concerns, and very specific outcomes that are desired. Those, the more specific the outcome, the better you can evaluate whether or not the outcome is achieved. It's evidence informed. It's constructional rather than eliminative. It builds on assets. It doesn't focus on what's wrong. That is, it focuses on the present. It looks at the context in which the behaviors occur, the problems occur. And when you do that, a lot of times it shows that the behavior makes sense, that the occurrence of the problem may be predictable. And so again, if you alter the environment, then those problems might go away. Has a clear description of the assessment methods used, and that there tends to be a close relationship between the assessment and the intervention itself. So finally, to wrap this up, I have a couple slides here on the kinds of things that the kinds of factors, I guess, that influence the options that are available to a client, things that are to be considered in a contextual assessment, and starting with the very big one, the global influences on local circumstances. For instance, um, you know the carrier air conditioning company just outsourced their jobs to Mexico, and 1,700 jobs were lost in Indianapolis and another 800 in a much smaller community up the road because that company also moved to Mexico, connected to carrier. Creates a lot of unemployment, creates depression, creates anxiety, sets up substance abuse, all sort of family breakups, all sorts of things. Social policies and legislations and the values connected to them. For instance, the idea that unemployment has to do with the individual's laziness, that people are receiving food stamps or the SNAP benefits, that they just need to be put to work, that there too many of them aren't working. Poverty is the lack of the individual effort. And it's an important point that is made here that eventually people come to regulate themselves through the internalization of cultural prescriptions. Victims of this tendency to focus upon the individual begin to believe it themselves. And sometimes you may have to help the client recognize what it is that's underlying some of the behaviors that and problems that they have. Giving attention to all the different levels of influence. We have to look at the social support systems because they're so important in not only developing resilience but maintaining that resilience over time. When we back away from treatment, the support system is the is the entity that is going to help the client maintain the behavior. The community and physical environment. What kind of environment is there that the client is living in? And you can imagine the kinds of issues that creates. What kinds of behavioral repertoires and reinforcers are available for the client? And the match between the task, what we have to change, and what we have to work on, and the resources that are available in order to do that or to accomplish it, because oftentimes we are limited by what we have at our fingertips, what we have available to us. Biomedical factors, physical causes that result in that can result in a lot of incorrect ideas about what the cause of the problems are. I was talking a little bit earlier about, I believe, about the issue with the thyroid problems and how that can be mistaken for behavioral problems, and how that can just set up medications of clients, and focusing upon changing behaviors that have a physical basis, and that aren't going to change without a physical intervention. And of course, we look at things like, is the person adequately receiving adequate nutrition? What's their drug, alcohol, caffeine intake? Those kinds of things. Fetal alcohol syndrome is a big issue in Alaska, and should never be overlooked. cognitive and perceptual characteristics, including intellectual deficits, use and abuse of substances, because that's going to affect the client's ability to think clearly and to reason. Emotions and feelings. It's not that attributing the cause of problems to feelings is wrong. It is that the account is incomplete if that's the only thing that we look at. Motivational differences, and is that motivational problem related to kind of just the client doesn't care about things, and if that's the case, even it's an indication probably there aren't adequate reinforcers in the environment to correct the problem. Religion and spirituality, as we've mentioned elsewhere, is more recently being recommended as a part of an assessment to understand the values and meanings that the client attaches to parts of his or her life. Of course, cultural differences in values and norms and communication styles, level of acculturation of the individual to the dominant culture. And finally, developmental issues and transitions. All of Social Work 642, in fact, it is sometimes those development influences, the genetic influences that affect patterns of behaviors at different ages as well, and that'll vary from culture to culture, as well. So, here's another take on an assessment. The contextual assessment gives you a kind of a broader picture about how to look for ways to intervene with a client, and I think this chapter is worth digesting and making a part of your knowledge repertoire as you go forward with your career. That said, I'll close off for now and wish you a good evening. Bye for now.